Thank you for giving me opportunity, Emirates Society of Internal Medicine. Thank you, Omar. Thank you, Bear. It's an honor really to be here to present this important topic. I think probably just... Okay, so I've been given this important topic of VTE and docs and treatment and beyond. I don't have any disclosures except that they have given me honor to present this topic. So we'll talk about learning objectives of today's talk. We'll take it, start with a real world case. We'll then discuss the VTE treatment in the view of guidelines, and we'll mainly talk about European Society guidelines and ASH guidelines and other guidelines. So we'll then discuss the use of DOACs versus warfarin in VTE. And we'll finally talk about extended VTE treatment, what choices we have and what's the evidence behind it. So starting with the real world case, 47 years old lady with no past medical history, on oral contraceptives for irregular periods, comes with a family history of hypertension in the father with no VTE history in herself and in the family, with breathlessness. And these are the vitals. So as you can see, she is tachycardic, her blood pressure is stable, saturating well, GCS 15, not much tachypneic, normal examination. There were abnormal labs, including troponin, slightly high, TROP-T, 14 being the upper limit of normal in our hospital, and BNP a little high as well. So no surprises here. We're talking about some sort of PE. We did the D-dimers, and D-dimers were high. Rest, all the blood results were normal. So there was no DVT clinically on examination. We proceeded with the ultrasound, and that showed no DVT. Again, as expected, as we should have done, we went for CTPE, and CTPE did show bilateral PE with no features of right heart strain and no saddle embolus. So we know that this patient, we are dealing with intermediate risk, or we can call it a submassive PE. This patient was quite stable, was discharged a few days later on rivaroxaban 15 milligram twice a day for 21 days, and then 20 milligram once a day for 3 months. So that's the usual story. We as an internal medicine colleagues deal with it on a daily basis. I don't think so there are any surprises. I'm not asking the questions about VTE or not, but my question is actually this. So I would like to engage my audience and ask this important question, considering the case which we just dealt with. Is this provoked PE? Is this provoked due to transient risk factor? Is this provoked due to persistent risk factor, or is this unprovoked PE? So if I can go back again on this scenario, but if you want to raise hand, who thinks this is provoked PE? So raise hands for who thinks this is provoked PE. So we have around 10, 15 people, okay? Who thinks this is provoked due to transient risk factor? So more than 50% feels that this is provoked due to transient risk factor. Who thinks this is provoked due to persistent risk factor? Okay, couple of people. And who thinks this is unprovoked PE? Okay, so we'll come to the answer. This will be the theme of my talk today. We'll go through the 3 questions in total, not a lot, and we'll get the answers. So just keep this in mind. So majority thinks it's maybe a transient risk factor, but there are a few other who thinks that this could be unprovoked or provoked as well. So this business of provoked and unprovoked VT, quite like you can say old slides, the 2019 and 12, talking about provoked VT comes from transient risk factor or persistent risk factor. When we talk about transient risk factor, there are some factors which are major, and there are some who are minor. So major, like surgery, major surgery with the general anesthesia more than 30 minutes, you have been in the hospital for more than 3 days, or some minor risk factors. And there are some who have no identifiable cause. Actually, we are moving away from these now, provoked and unprovoked VTE. Before we why we actually bothered about this? We bothered about this because this is a risk of recurrent VTE. So for instance, If they have a patient with a provoked by surgery, you have a almost zero risk and not much risk of recurrent VTE. But on the other hand, if you have a provoked by the non-surgical risk factors, or especially if it's unprovoked, look at that. After 3 months, suddenly the risk of recurrent VTE starts going high, high, and high. So essentially, that these are the patients who might not get much benefit by just giving treatment for 3 months. So 3 months might not be enough for these patients. So I really like now this, and I would ask you to follow these ESC 2019 guidelines. These are the traffic light system of, you can see green, yellow, or red. So what we're talking about, if you have a low risk of recurrent VTE as a green, so essentially you have a patient with a major transient risk factor like a surgery or being in the hospital for more than 3 days or trauma with fractures, you don't have much recurrent risk of VTE. On the other hand, if you are high risk, like you have an active cancer, you have recurrent VTE, or you have antiphospholipid syndrome, then for sure you are going to extend the treatment. You are going to consider the treatment extending it beyond 3 months. But you have this yellow or orange population as well. And one of these is our patient who's got estrogen, or like who's been either pregnant or has been on oral contraceptives. You also have long haul flight as well. You also have a patient who has been in the hospital, confined to the bed, out of the hospital for more than 3 days. So there are some risk factors which are actually in the middle. So essentially, it really matters that what risk factor is bringing this patient to having the VTE, because if you don't consider it, you might want to stop, okay, or you might want to extend it further. So talking about our answer, it's actually provoked due to minor transient risk factor because it was an intermediate risk PE. So that takes me to my next, like, what are the goals of VTE treatment? So, okay, so it can recur. So what happens if it recurs? You want to prevent the recurrence of the VTE because it's a high morbidity. You can also have post-thrombotic syndrome, and you can also have CTAF. So as you know, CTAF is chronic thrombotic embolic pulmonary hypertension, but also remember, you have to minimize the bleeding risk. So that takes me to my next question. So for VTE treatment, so once we have decided that we want to give the VTE treatment, who thinks that warfarin is the better choice than DOACs for recurrent VTE risk? Who thinks the warfarin are better than DOACs for bleeding risk? Who thinks that DOACs are superior to warfarin for recurrent VTE risk? And who thinks that DOACs should be the first line of choice for VTE treatment? So one of them is correct, actually. So raise hands for A. No raised hands, okay. Raise hands for B. Raise hands for C. So there are few hands that DOACs are superior to warfarin for recurrent VTE risk. We'll come to that in next few slides. And raise hands for DOAC is the first line choice for VTE treatment. So majority. So that takes me to this from European Society of Cardiology, looking at the DOACs or NOACs, what we can call them for VTE selection as per risk profile. So as you can see, there are 4 major drugs which we have among the DOACs, and all of them have these randomized trials, not head-to-head trials. You have to keep this in mind. So this is RECOVER trial. You can see for Debi versus warfarin. You have Einstein trial, where enoxaparin versus rivaroxaban. You have Amplify trial. Again, apixaban was compared, and the edoxaban versus warfarin. And the major idea is that they're all not superior. They are non-inferior to warfarin. So, you know, when one of the choices was superior, this is not superior in terms of recurrent VTE risk. They are just non-inferior to warfarin. So what about the bleeding risk? So of course, you can see the hazard ratio all throughout about the Debi, the rivaroxaban, apixaban, edoxaban. As you can see, the comparison, the hazard ratio are quite low. So they are actually, DOACs are associated with less major bleeding than warfarin. So the bleeding wise, of course, the DOACs are quite good in terms of bleeding profile. So they're non-inferior to warfarin, but the bleeding wise, they are much better than warfarin, all across the DOACs. So this is the systematic review and meta-analysis done among the DOACs again. And again, you can see among the major bleeding, you have a major advantage that it favors towards DOAC, okay? And the net clinical benefit goes towards the DOAC as well. So that takes you to ASH guidelines. ASH guidelines clearly in 2020 recommended that DOAC should be considered over vitamin K antagonists, but one does not suggest one DOAC over another. So there is no one DOAC saying that that should be suggested over another one, but overall DOAC should be the first line of treatment for VTE risk, and that also recommended by the European Heart Journal Association, again saying the ESC, saying when oral anticoagulation is initiated in a patient with PE who is eligible for DOAC, DOAC should be the recommended, so 1A treatment, 1A recommendation again. So question 2 answer was that DOACs are first line of choice, so they are not better than DOACs. Warfarin is not better than DOACs, they're non-inferior. Warfarin is definitely not better than DOACs, rather DOACs is better than warfarin for bleeding risk. And DOACs not superior to warfarin, they are non-inferior to warfarin for recurrent VTE risk. So, okay, so we established that the VTE can be recurrent. It depends on the risk profile, but also do you want to see that whether if I continue with the anticoagulation, what is my recurrence risk and what is my bleeding risk? But don't forget the patient choice, because patient also needs to know whether they want to extend the treatment beyond 3 months, beyond 6 months or not, and what's the reason. They might be having side effects with that. They might not like the DOACs. They might not like one DOAC over the other DOAC. So you need to consider the patient choice as well. So that takes me to the next question. So in our patient who was given treatment, let's say for 6 months for VTE, because she was at intermediate risk for VTE, would you like to stop rivaroxaban at 6 months? Would you like to continue rivaroxaban for 20 milligram lifelong, once a day? Would you like to switch rivaroxaban to aspirin, because we think the aspirin is less risky? Would you like to switch rivaroxaban to 10 milligram once a day after 6 months? Or would you like to switch rivaroxaban to apixaban 2.5 milligram twice a day after 6 months? So raise hands for A. So quite good few number who thinks that we should just stop at 6 months, okay? Raise hands for continuing lifelong. So I'm glad that not many of you want to just continue for lifelong. Switch rivaroxaban to aspirin lifelong. So a couple of people actually do want to switch it to aspirin. Switch rivaroxaban to 10 milligrams, so go on a lower dose. So there are few who would like to go on a lower dose after 6 months. Switch rivaroxaban to apixaban after 6 months. So there are few again who wants to go to apixaban. Okay, so we'll go to further few slides to try to explain this. So remember this, like as I said about the patient choice is very important here. And also the risk factor was in this case was actually the contraceptive pills. So what's very important is that are they gonna stop the contraceptive pills or not, okay? And are we going to stop any other risk factors or not? So this patient was also obese. So obese is another risk factor as well, okay? And that comes into intermediate category as well. So again, for extended anticoagulation treatment, there have been several trials. You can see Dabi, rivaroxaban, apixaban, aspirin, solidoxide, all had, I will not go into the details of this, but these are the majority of trials done for extended anticoagulation treatment. So starting with the rivaroxaban, as you can see that rivaroxaban was compared with placebo, and we saw that there was 82% relative risk reduction, so quite a big reduction of recurrent VTE risk. When you see the major bleeding, again, only 4 events, so that was at the expense of 4 major bleeding events, but remember, there was no death, there was no mortality, there was no bleeding in a critical site, and mainly, among the 4, there was 3 GI bleeding. One of my previous speakers also talking about DOACs with problem in patients with the GI bleeding and cancer patients, okay? So some who have GI bleeding or who have menorrhagia, that was the major bleeding events happened in the Einstein study, in Einstein extension study. So rivaroxaban then looked into that, why don't we actually extend the treatment beyond 6 months and see whether we can have the same dose of 20 milligram compared with aspirin or 10 milligram compared with aspirin again. So what they saw that in terms of incidence, again, the event rate was relative risk reduction of 66% when 20 milligram compared with aspirin. And again, 10 milligram, you can say relative risk reduction of 74%. So there is quite a lot of reduction in terms of recurrent risk of VTE when you extend it. Now, why it was compared with aspirin? Because aspirin was already proven in some of the orthopedic studies in recurrent risk of VTE. That's why they compared with aspirin. They were not compared as three-way trial. It was compared 1-to-1 with 10 milligram and 20 milligram dose. They also looked at the risk of the bleed then, and that what they found is that a very low risk, as you can see, with 20 milligrams, 6 events versus 3, and then in 10 milligram, 5 events versus 3. And as you can see, very similar to aspirin, the bleeding profile. So in a nutshell, that if you extend the treatment beyond 6 months of rivaroxaban, the 10 milligram do the same benefit and with the same bleeding profile or even less bleeding profile than the 20 milligram. So if you are going to extend it beyond 6 months, you might consider it to continue with 10 milligram rather than 20 milligram. So Amplify Extension also looked into apixaban in the same way with 2.5 milligram and 5 milligram, and they compared with placebo, and they found the similar results as well. In the Remedy and Resonate trials, we saw the Debbie was compared with warfarin, and Debbie again was compared with placebo as well, and again, very similar results, not as dramatic as rivaroxaban and apixaban, but there was a trend showing that they will be beneficial as well. This is aspirin compared with placebo, and of course, like as I showed you before, in Aspire and Varfasta trial as well, that overall the clinically relevant bleeding and the recurrent risk of VTE majorly advantage of recurrent risk for VTE for aspirin. So that has again translated into guidelines in the NICE, as you know, from UK in 2020 guidelines. They asking us to do the benefit to risk assessment profile at 3 months regarding extending the treatment for patients with unprovoked VTE. So they're saying if you have a provoked major transient risk factor, you stop. If you have an unprovoked or persistent risk factor, you extend with the patient preference. So you also consider Has blood score, considering their bleeding profile. And if the current treatment is not well tolerated or the clinical situation or preferences have changed, you can switch from rivaroxaban, for instance, to apixaban. If they, for some reason, they're already on, let's say, rivaroxaban and they don't like rivaroxaban, then you can switch it to apixaban. So the people who, for full stop, they need anticoagulation, but they would like to stop anticoagulation, they would like to carry on with aspirin, you can give them an option of aspirin as well. I personally like the ESC guidelines. It's a busy slide. I'll take you one by one. To start with, what we just discussed, they say that the patients who have a major transient or reversible risk factor, you stop after 3 months. So this is like initially we discussed just the NICE guidelines. Now this is ESC 2019 guidelines. Patients who have either recurrent VTE or who have antiphospholipid syndrome, you have to extend beyond 3 months. So you have to see that you have to go beyond 3 months for these patients. The patients who you have identified who have no identifiable risk factors or who have a persistent risk factor, again, are the ones who we should be considering extending it beyond 3 months. When you have a minor transient or reversible risk factor, this is another condition where you will consider extending it beyond 3 months. So we have definite 2 ones where recurrent VTE and antiphospholipid syndrome, where you almost for sure you will extend, and you will consider to extend it if you have no identifiable risk factor, which we used to call as unprovoked, if you have a minor transient risk factor, or if you have a persistent risk factor, like cancer, for instance. Once you have decided that you are going to extend it, okay, beyond 6 months, what you can do is that you can give either apixaban 2.5 milligram twice a day, or you can give rivaroxaban 10 milligram once a day. So rather than continuing with the same doses, except it's a cancer patient, you can carry on with a lower dose. In the patients who don't like anticoagulation, you do have an option of aspirin to be given as well. So going back to your my initial question, for sure, in our patients, you can have an option, especially if for any reason you have a persistent or an ongoing risk factor, you can switch rivaroxaban to 10 milligram after 6 months, or rivaroxaban to apixaban, 2.5 milligram twice a day, if they have a preference of taking tablet, for instance, twice a day after 6 months. So last few slides. This is just, I wanted to show you the systematic review and meta-analysis again after discontinuation of anticoagulation, how risky it is. So if you can see that 18 studies, 7,000 patients with an unprovoked VTE. If you stop, okay, you have a recurrent risk of 10% in the first year, 16% 2 years, 25% 5 years, 36% at 10 years, with 4% of recurrent events resulting in death. So you have a large risk of recurrence, especially if it's an unprovoked, or what we can say that there is there is no identifiable cause. This is another one, systematic review and meta-analysis done on extended DOAC therapy, and essentially the findings are that for 1 year in patients with clinical uncertainty for ongoing anticoagulation can reduce VTE recurrence and mortality. However, it could increase clinically CRNM, what we call as clinically relevant non-major bleeding. So it comes, of course, at the expense of some minor or non-major bleeding events. So ASH, like what we just said in American Society of Hematology guidelines, said that DOACs are the first-line treatment. DOACs should be preferred over VKAs for most patients with severe renal insufficiency, moderate to severe liver disease, or antiphospholipid syndrome. So except these patients, so you should be definitely going for DOACs. Although we are now more and more talking about patients with severe renal insufficiency, in some cases these DOACs are coming in. And for now, of course, antiphospholipid syndrome, you don't go with DOACs. So they recommend to give you either the initial management for first 5 to 21 days as a primary treatment, then 3 to 6 months, or secondary treatment beyond the first 3 to 6 months. They favor shorter courses, of course, because if it's a transient risk factor, but indefinite anticoagulation for most patients with unprovoked or DVT with a chronic risk factor, like as I said, if it's a risk factor which is persistent. Some of us have concept of doing the prognostic scoring, D-dimers testing, or venous ultrasound to guide the duration of anticoagulation. Actually, the ASH is not suggesting that, so they are against the regular use of D-dimers, prognostic scoring. You know, like after 3 months or 6 months, you bring the patient in your clinic and you would like to do the D-dimers, you would like to do the ultrasound to see. So there's not much evidence behind it, although some studies are showing this, but there's not much evidence. So in summary, VTE can be recurrent and should be risk stratified. I would highly suggest to use this traffic light system where you see that where is your patient. DOACs are the first line treatment for most of the patients. They do offer the better bleeding profile, and that's their major advantage, although they are non-inferior to warfarin, except the other advantages of DOACs over warfarin about not monitoring required. You do consider extended VTE treatment because that gives you an option of extending, especially if the recurrent risk of VTE is still there. But remember, there's no one size not fits all. So every DOAC has its own advantages. Some people like once a day, some people like twice a day. Some have more bleeding profile better, some have other advantages as well, okay? So you have to consider each DOAC in its own merits, but there is evidence, what we just saw in some of the guidelines coming up, more DOACs than the others. Thank you.